Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in.
Hello, and welcome to this continuing education course for the EMR. This is Medical Emergencies Part 1, presented to you by EMT-CE. We are going to begin this course by talking about neurological emergencies, which is a really big one for anyone working in the field of EMS. The first thing that we note with any sort of neurological emergency is altered mental status. So altered mental status is defined as any alteration of a patient's normal mental baseline, and this can be caused by a multitude of factors, so a thorough assessment must be done on these patients. Now, a really good way to perform a thorough evaluation, and this is something that you're going to encounter in both Part 1 and Part 2 of the Medical Emergencies courses, is AEIOU tips. And this is used to kind of rule in or out virtually all possible causes of altered mental status, and it can help you pinpoint what might be going on with the patient. So we have A for alcohol, E for epilepsy or seizures, I for insulin, so this could be a diabetic condition one way or the other, meaning hyper or hypoglycemia. Oxygen, and of course this is going to most often be a lack of oxygen. Uremia, so we have kidney failure. T for trauma. I for infection. The first P is a psychiatric condition. The second P is poisoning. The first S is shock. The second S is stroke. So again, we'll be going through a few of these that are related to a neurological emergency. In the next course, you'll see a few more of these. But if you can at least ask questions or gather history or use the environment that you're finding the patient in to rule in or out some of these, even things like insulin, gathering a blood sugar, taking their oxygen saturation, asking about history of seizures, you can smell or see possible alcohol abuse, looking for signs of infection, things like that can help you deduce what's going on with the patient. So we will talk a little bit about seizures. This is, of course, a big one for neurological emergencies. There's a couple different kinds of seizures. There's generalized seizures and partial seizures. Generalized seizures include tonic-clonic, or what used to be understood as a grand mal seizure. So that's where we see more convulsions. Then we have absent seizures, where a patient can kind of go blank. This is sometimes hard to even see in a patient. They might stare into the air, they might make a repetitive noise, or be picking at something, or just doing a behavior over and over and over again. So we know that a generalized seizure is typically going to involve the entire brain. Then we also have partial seizures. So we know that with a partial seizure, it's partial because it really only affects a single part of the brain. And then we have simple and complex. This is often deemed simple or complex based on whether or not there's a loss of consciousness. So a simple partial seizure means that there is often no loss of consciousness, while a complex partial seizure is often associated with an impairment or loss of consciousness. And so sometimes individuals with seizure disorders are more prone to one type of seizure, but again, trauma and substances can also lead to seizures. Now, status epilepticus is defined as any of the following, and it's a continuous seizure lasting more than 30 minutes, so a single seizure that lasts for more than 30 minutes, or it can be 2 or more seizures without regaining consciousness in between. And there's less of a time frame on that. So if a patient has a seizure, that seizure stops, but they don't regain consciousness, and they have another seizure, that's now considered status epilepticus. Any prolonged seizure lasting between 5 and 30 minutes should be treated as status epilepticus. So even though it's often defined as one lasting more than 30 minutes, if it's lasted longer than 5, we're kind of treating it the same anyway. Some complications involved with the seizure are aspiration, and that's because sometimes there's fluid. It could be emesis, excessive saliva that a patient might inhale. Bone and spine fractures, especially if a patient has fallen or is seizing in a dangerous area. They can hit their head, they can hurt their back, their arms, etc., with really violent body movements. There can be brain damage from a lack of oxygen and or depletion of glucose. So a couple things that happen during seizures is that oftentimes a patient's breathing is going to be interfered with, and that's especially problematic for those longer lasting seizures. So if they go without oxygen or adequate oxygenation for a long period of time, they can have brain damage. And then depletion of glucose. So that seizure activity quickly uses up glucose and glycogen stores in the body, so they can be severely hypoglycemic, which we know further exacerbates their problems. It can also cause dehydration. So it's just really hard on the body. They can sweat a lot. They might, again, aspirate. They're breathing irregularly or really quickly. And so all of that can also contribute to dehydration. Some possible causes of seizure can be medication non-compliance. So a patient might have a seizure disorder and they're not taking the medications that they know they're supposed to be taking, and now they get a seizure. A rapid increase in body temperature, so a febrile seizure. Most often we see these in kiddos under 5. And what happens most often is when a child spikes a fever quickly. So though it's possible, it's not often seen in a body temperature that slowly rises. It's a kiddo gets sick and again spikes a fever and a high fever. So we see those really high temperatures quickly, and little ones' brains are already very sensitive. They're developing. There's a lot of connections being made. And while it's not completely understood, it's thought that this quick rise in body temperature interferes with some of those already sensitive neural connections, and it can trigger a seizure. Febrile seizures are often truly low risk. As long as you can cool the patient, there's rarely any lasting problems, and they're relatively common with little ones. So they're truly not problematic, but it is important to cool that patient. That's where acetaminophen is helpful, and then just cooling that patient, right? Taking clothes off, getting them into cool water, or getting them some ice packs, things like that. An infection can cause seizure. Low oxygen can cause seizure, and we know that seizure can also cause low oxygen, so it can be kind of a downward spiral. TBI, so increased intracranial pressure if there's bleeding in the brain, bruising in the brain, or damage to neural tissue in the brain can all contribute to seizure. Alcohol or drug withdrawal, that's a big one. So substances, we know that the use of substances or withdrawal from substances can all contribute to seizure. Stroke, so bleeding or deprivation of blood in the brain can cause seizure. Hypoglycemia is a big contributing factor to seizure, and as we just learned, continued seizure can cause hypoglycemia. So again, another downward vicious cycle. Eclampsia, so the difference between preeclampsia and eclampsia is actually the onset of a seizure, and this is seen in pregnancy, and it can actually be seen in a short duration post-pregnancy, like after delivery. Preeclampsia is caused by hypertension. Now, this hypertension can lead to a variety of symptoms, including headache, changes in vision, peripheral edema or swelling in the extremities, and then the key sign is protein in the urine. This occurs because of kidney damage that causes the kidneys to excrete protein. If this condition advances into eclampsia, the patient is at risk for kidney failure. Besides the kidneys, there's other organs at risk during preeclampsia. What's important for us to understand is that if a patient has preeclampsia and has had a seizure, that indicates that they now have eclampsia, which is an immediate life threat to both mom and baby. A seizure disorder, so that kind of goes with medication noncompliance, electrolyte disturbances, and poisoning. So these can all trigger seizures. When you're assessing a patient with seizure, you have to understand they're not all these tonic-clonic or what's previously known as grand mal, very obvious seizures. You can see seizures that might honestly not look like a whole lot. So you do have to be aware they're not all fall on the ground, seize all the muscles, kind of a thing. Sweating, cyanosis. Again, we know that sometimes with seizures, a patient's not breathing, and so they can be cyanotic. Increased secretions. Again, we talked about aspiration being a problem during seizure activity, and so they might have increased secretions. This can be a problem and put them at risk for aspiration. There may be incontinence, so there's a loss of urine or fecal matter. And then there's a postictal phase. So a lot of times when a patient has a seizure, they don't just bounce right out of that seizure. There's going to be kind of this lethargic period following a seizure where a patient is slowly coming to, and they slowly kind of remember who they are, where they are, who's around them, possibly what happened. They might remember that they had a seizure. A lot of times if a patient has a seizure disorder, they also have, it's called an aura, or these kind of signs that indicate that a seizure is coming on. So there might be smells or visions or like a taste, something that indicates that a seizure is coming on. And sometimes they can alert you to the fact that they might be having a seizure. Again, this is typically associated with a seizure disorder, not a single onset of a seizure. Managing patients who are having a seizure, the big one is protecting them from further injury, so getting them in a position where they can seize without further injury. Position them on their side if you can to protect their airway. Again, we talked about how there's extra fluids, emesis, spit in the airway, so if you can get them in kind of a recovery position and keep fluid from entering the airway, then you can save them a lot of future damage. It's always about keeping that airway open and patent. Again, with some of the partial seizures, there might not be a risk to the airway, but if there is a loss or change in consciousness, you might need to help them protect their airway. And then trying to ensure adequate ventilation, oxygenation. This could involve sectioning their airway as well. And then consider using an NPA. This might be easier than their mouth, inserting it through their nose. And then just providing emotional support, especially as they emerge from a seizure. It can be very scary, very disorienting. So providing emotional support and then reducing stimulants that might trigger more seizures. So this is helpful if you or the patient or somebody around them knows what is triggering the seizure in the first place. If you can reduce those stimulants, that would of course be helpful for the well-being of the patient moving forward. Next, we're going to move on to endocrine emergencies, and we're going to talk a little bit about the endocrine system and then talk about some emergencies associated with the endocrine system. The functional unit of the endocrine system would be the endocrine glands. So the endocrine glands secrete hormones, and those hormones have a widespread effect on the body or have the capability of having a widespread effect on the body. Hormones will exert effects on target organs, but they're also involved in regulating cell processes and body functions. So a lot of our endocrine disorders are caused by either too much or not enough of the release of these hormones. Hormones really are involved in every function of the body to some level. And so it's really important that we understand how the system works. So we have various endocrine glands. The first is the hypothalamus. The hypothalamus is located deep in the cerebrum, and it's actually the junction between the central nervous system and the endocrine system. We have the thyroid, and that's what this image is right here. It's located in the neck, just in front of the laryngeal cartilage. and it's involved in regulating metabolic function. It's this butterfly-shaped gland, and it's two lobes connected with an isthmus of tissue. And then on the posterior side of that thyroid are the parathyroid glands. Most cases, there's 4 of these. They're about 5 millimeters, and they are involved in the regulation of blood calcium levels. The secretion of the parathyroid hormone increases blood calcium levels, and it often does this by breaking down the bone where calcium is stored. Next, we have the pituitary gland, and the pituitary gland is real small. It's a pea size, and it's located just below the hypothalamus. And there's 2 lobes. There's the anterior lobe and the posterior lobe. The posterior lobe secretes ADH, or antidiuretic hormone, so it helps retain fluid, and then oxytocin. And oxytocin is a kind of a bonding hormone. One example of when it's released is when nursing, and this kind of creates a bond between mom and baby. It also stimulates uterine contraction. The anterior pituitary, on the other hand, is considered the master gland. And that's because it regulates all the other endocrine glands, and it does this through some of the hormones that it stores. So it basically stimulates a lot of function from the other endocrine glands. The thymus is located behind the sternum, and it's large in children, and it's involved in the maturation of the immune system. And so once it helps that maturation of the immune system in kiddos near adolescence, its function decreases and it turns into a small remnant of fat and fibrous tissue in adults. So it's much less utilized in the adults. Then we have the adrenal glands, and these sit just on top of the kidneys. They have a capsule, and then they have the cortex, which is the external portion, and then they have the medulla, which is the internal portion. The adrenal medulla is responsible for secreting epinephrine and norepinephrine, and that stimulates the sympathetic nervous system. So that's kind of our fight or flight response. That's when our body kind of goes into overdrive to protect itself. The adrenal cortex is the outer portion, and that secretes steroidal hormones. There's a few different classes of steroidal hormones, but mostly they're involved in kind of growth and development, also involved in energy and metabolism, reproduction, things like that. Next, we have the pancreas, and the pancreas is located just behind the stomach and in between the duodenum and the spleen. So it has endocrine and exocrine functions. Endocrine, like we're talking about here, is when hormones are secreted directly into the bloodstream. Exocrine glands actually secrete a substance into a duct, and then those are used through a ductal system. And the ductal system in this case involves the liver and gallbladder, but we're going to talk about the endocrine function of the pancreas today. So the endocrine tissue is found in the islets of Langerhans. We have alpha cells, beta cells, delta cells, and they're essentially secreting hormones that are involved in blood sugar regulation. Glucagon and insulin are the 2 big hormones, and we'll talk a little bit more about those later. Next, we have the pineal gland. This is located in the roof of the thalamus of the brain, and it releases the hormone melatonin. And melatonin, while it's still being researched, does play a role in the circadian rhythm. So our body's response to changes in light, our biological clock, and day length. So sleep-wake cycles and other biological clock functions. Then we have the gonads. So these are responsible for sexual maturation, puberty, reproductive function. In the females, the ovaries are the female gonads. They secrete estrogen, which will help in the maturation of the female. And then the testes are the male gonads. They secrete testosterone, and they're involved in the maturation of the male system. Now, besides glands, there are a few organs with endocrine activity. One of those is the placenta. The placenta secretes human chorionic gonadotrophin hormone, and that is, of course, involved in growth and development of the fetus. HCG is actually what's tested in a pregnancy test. Then there's the intestinal tract, so our GI system, and that secretes gastrin and secretin. So gastrin is involved in the secretion of gastric juices to help promote digestion. Secretin is also involved in digestion, and it helps regulate gastric acid. It's involved in some pancreatic bicarbonate, and then it's also involved in fluid regulation within the GI system. The heart produces atrial natriuretic hormone, or ANH, and this is involved with controlling blood pressure and electrolyte balance, so kind of also fluid regulation within the body. And then the kidneys secrete renin and erythropoietin. And renin is involved in sodium and potassium regulation, which kind of indirectly helps control fluid levels in your body. And erythropoietin is involved in the production of red blood cells. So all of these organs do have this endocrine function, which play roles in some of the most important functions in our bodies. Now we're going to talk a little bit about some disorders of the endocrine system. We're going to focus primarily on diabetes because this is something that we're going to see a lot, and it's something that we can manage. We have the most control over in the field. So diabetes mellitus is a disorder of the pancreas. There's type 1 and type 2. There's about 15 to 16 million diabetics in the United States, but this is an ever-growing number. So what happens in diabetes is there's improper regulation of glucose. Glucose is a really large molecule that cannot readily pass through the semi-permeable cell membrane to meet the body's energy demands. So what this means is glucose is essentially sugar that the body can use for energy. It's a fuel source. However, in order to have any sort of effect, it has to get into the cell where the cell can use it for cellular processes. Glucose is a large molecule though, and it can't get through the membrane of the cell without some sort of facilitated transport. Insulin is the hormone that's actually required to move glucose into the cell. So what happens with diabetes mellitus is, for one reason or another, insulin is either not present or is ineffective in moving glucose across this membrane. We're going to talk about two types of diabetes and how insulin functions within either of these. And now, in general, normal blood glucose levels would be 80 to 140 milligrams per deciliter, and it depends on the time of day. So did the patient just eat? Has it been a while since they've eaten? But either way, the body should be able to fairly tightly control the blood glucose levels. What happens is kidneys filter the blood, and they can't reabsorb more than about 180 milligrams per deciliter of blood glucose. So in diabetes, the way diabetes is recognized is glucose levels exceed this 180 milligrams per deciliter, and so it has to be lost in the urine. It can't be reabsorbed. The kidneys have met their max, so it's lost in the urine. When glucose is lost in the urine and there's glucoseuria, this is a strong indication that there's diabetes because there's too high of circulating blood glucose levels. You'll also get a high capillary blood glucose, or CBG, reading. So for type 1 diabetes, this used to be known as juvenile onset. It's not anymore because it can happen later in life, but essentially pancreatic beta cells are no longer producing and secreting sufficient amounts of insulin that are required by the body. Now, sometimes this can happen from damage. For example, a viral infection can damage these beta cells so they don't produce insulin any longer, and a patient can become a type 1 diabetic. In other cases, this is more congenital, and for whatever reason, early in childhood, an individual's beta cells are rendered ineffective for one reason or another and are no longer producing insulin. So when insulin is not produced, it can't be used to shuttle that glucose across the cell membrane. So glucose builds up in the bloodstream, the cells become deprived of glucose, and they're essentially starving. Blood glucose rises, glucose is lost in the urine, and then the body now turns to fatty acids as their primary energy source without glucose. When fat is burned, it leaves behind ketone bodies. Ketone bodies are naturally acidotic, so it puts the body in a state of metabolic acidosis. So we have too much acid in the body, ketone bodies are being burned, which are a less efficient fuel source, and this is where we get DKA. DKA, or diabetic ketoacidosis, is a slow onset. Again, it's this chronic buildup of glucose. It's this slow depletion of the cells of energy and an inability to use glucose. So it turns to fatty acid over time as these ketone bodies build up. Then you get to a state of metabolic acidosis. In this state, we're losing a lot of fluid, and we know that because glucose is being lost in the urine, this large cell via osmosis pulls water with it. This means a lot of water is lost in the urine, so the patient is becoming dehydrated. So they're urinating a lot, which is polyuria. Then they become thirsty because they're losing a lot of fluid. That's polydipsia. And they become hungry because their cells feel like, even though there's a lot of glucose present, the cells think they're starving because they're not getting any of it. So the person becomes very hungry. This triad of symptoms, polyuria, polydipsia, polyphagia, are indicative of an individual who is diabetic. So we get dehydration, dry, warm skin and mucous membranes from that dehydration, abdominal pain, nausea, vomiting. They're in an acidotic state, and they also become tachycardic, most often because they're dehydrated and they're low on fuel. They can also get a fruity odor on their breath, and this is the ketone bodies. It's a kind of sweet odor on the breath that's truly indicative of diabetic ketoacidosis. What we see after a patient has become acidotic over the course of 12 to 24 hours, they try to offload carbon dioxide, and to do this, they take fast and deep breaths because they're trying to offload as much carbon dioxide as possible to reach homeostasis. These are called Kussmaul respirations. If you see fast, deep respirations, that points towards metabolic acidosis, and one of the most common forms of metabolic acidosis is diabetic ketoacidosis. If left long enough, this can progress to unconsciousness and coma. Managing this involves ruling out other causes. You can do this by taking a blood glucose. Oftentimes you'll get just a high reading, and then obviously gather a history. History gathering is going to be number one for helping rule in or out diabetic ketoacidosis. Maintain ABCs and get them to the hospital quickly. Really what they need is insulin, and that's something that even at the ALS level we can't give. That's something that has to be given in the hospital because just a little bit too much can cause a severe drop in blood glucose, and that's super dangerous. That gets into that seizure territory like we mentioned before, and can cause a patient to tank very quickly. For type 2 diabetics, this used to be known as adult onset because this is something that often happens later in life after a patient has built up insulin resistance. So essentially what happens is really high levels of circulating glucose over a long period of time means that the patient is also circulating high levels of insulin, and the body can become desensitized to insulin. At that point, insulin isn't as effective, and so while it's present, it's still not shuttling glucose across the cell membrane well. One reason that this might happen too is, for example, obese patients have more fat cells. Fat cells are less responsive to insulin, and so again, we get this insulin resistance. However, insulin's very present is usually enough to prevent the body from switching to fats as a primary energy source. So while a lot of the symptoms are the same, type 2 diabetic patients who still are making insulin get hyperosmolar, hyperglycemic, non-ketotic coma. Now, it's not always coma, but it can progress into a coma. However, because they're not burning fatty acids and getting those ketone bodies, they don't get ketoacidosis. However, it still develops over several days. You can get much, much higher levels of blood sugar. You still get polyuria, polydipsia, polyphagia because you're getting those high levels of blood glucose. It's being lost in the urine. It's pulling water with it. The patient's becoming thirsty. They're urinating a lot, and they're hungry because their cells still feel starved. So you still will get dehydration, tachycardia, and orthostatic hypotension. So when they stand up, their blood pressure drops because they're dehydrated. And then they can lose consciousness and actually enter a coma. Management is very similar to DKA. Rule out other causes, so do a very thorough history, take a blood sugar, maintain ABCs, and provide rapid transport. These people do just need more insulin for the most part, but they need a higher level of care. On the other end of this spectrum, we have hypoglycemia. So in this case, we have too much insulin or not enough glucose. So the body needs glucose. We know that, right? The cells require glucose. If there's not enough glucose present, we can get hypoglycemia. If a patient takes too much insulin, it shuttles way too much glucose in the cells. There's no circulating blood glucose. And after that is used up, can become very quickly deprived of glucose. So it's a much more rapid onset because too much insulin is taken. Now there's not enough circulating blood glucose. And now we have a kind of a downward spiral for our patient. This can also mimic other emergencies like a stroke. So it's really important to take a blood glucose if you notice signs of altered mental status. AEIOU tips that we talked about. I is for insulin, and that is a blood sugar emergency. So anytime, again, with altered mental status, that's part of your looking at your mechanism of injury, nature of illness, taking a blood sugar. With hypoglycemia, patient will kind of lose color, get cool, clammy, fast heart rate. They'll feel hungry. They might go weak, and then they're going to potentially seize and go unconscious. The problem with this is if you catch it early enough, you can give that patient very simple forms of sugar. However, if they go unconscious, now you can't give them anything orally, and it has to be administered via IV or an IM injection. And so you want to try to catch them before they can't follow directions. Again, managing this is ruling out other causes, determining their blood glucose level, and then once you note that it's low, so typically below 50 to 60 can cause problems. However, some patients are just chronically low, so they might have lower readings and still seem fine otherwise. However, just know that below those 60, 50 values, you're looking at hypoglycemia. So managing this patient involves getting them to swallow some sort of simple sugar. We do have glucose paste or gels that they can swallow, and that's a really simple form of sugar. Juice is a good idea, a hard candy, something with a real simple sugar. We want something super simple that their body can access quickly. Okay, so that is going to be the end of our discussion on endocrine emergencies. Now we're going to move on to immunological emergencies. We are going to begin by talking about an allergic reaction. But before we do that, I want to talk a little bit about the immune system in general. So the immune system is a pretty incredible system in our body. And the interesting thing about it is we have different types of immunity. Now, the type of immunity that we're primarily going to be focusing on today is our adaptive immunity. We have some innate immunity that we are born with. We have passive immunity that we can acquire through another source, like how infants gather antibodies from breast milk from their mothers. This is an adaptive immunity. It's basically how our body responds and essentially adapts to the world around it. Now, what happens in an allergic reaction is that a patient is exposed to some sort of allergen, and it's something that the body, for whatever reason, perceives as a threat. After this initial encounter, you're not going to see an allergic reaction. What the body instead will do is form antibodies, specifically immunoglobulin E. Immunoglobulin E are basically antibodies that are produced by the immune system. And what happens is the next time this allergen is encountered, these antibodies mobilize for attack. When this happens, you get an exaggerated immune response, and that's when you get the symptoms of an allergic reaction. Essentially, these antibodies release chemicals, and this chemical cascade causes the immune reaction. So we can get essentially blood vessels leaking out white blood cells, we can get swelling of tissues, we can get this reaction of our mucous membranes, which is why we can get sneezing, itching, watery eyes, runny nose. So all of this happens because of this immune reaction to something your body is perceiving as a threat. So we have the introduction of the allergen, the formation of IgE or immunoglobulin E. This antibody releases chemicals. When it encounters that allergen again, it begins this chemical cascade, and now we got all the symptoms of an allergic reaction to something that really shouldn't be causing a whole lot of problem at all. Now, if this remains localized, we get redness, swelling, hives, itching. So when we think of a localized allergic reaction, we're thinking of potentially some mild swelling from a bee sting. I think of poison oak, or you can think of something like pollen and dander in the air that might cause excessive sneezing, itching. You can even have some foods that you can have a more mild allergic reaction to. We do have to be aware that every time your body encounters this allergen, the symptoms could get worse. They have the potential to be exacerbated as your body mounts an increasing immune response. So some other examples would be nausea, vomiting, diarrhea. But ultimately, with a localized allergic reaction, there's usually minimal need for supportive therapies, right? You can think of somebody who has an allergic reaction to maybe poison oak. They might need some lotions or some creams or ice, things like that. But ultimately, they're probably not seeking hospitalization. Now, like I said, repeat exposures can lead to anaphylaxis. When we think about this, people with like bee stings or peanut allergies or things like that can cause really severe reactions, especially after repeat exposures. But typically, minor allergic reactions require very minor therapies. Now, with an allergic reaction, there can be multiple body systems affected. And we talked a little bit about this, right? We talked about the vascular system, it becoming a little leaky, releasing some white blood cells. We talked about our integumentary system, right? Some of those mucous membranes releasing fluid or causing sneezing, itching. We talked about nausea, vomiting, so we have some GI upset. We can have some itching, right, which is going to involve a little bit of our nervous system. So a lot of systems are involved in an allergic reaction. We might have a change in heart rate or a change in respiratory rate. The life-threatening reaction of the immune system to an allergen is going to get closer to anaphylaxis. So if there's large quantities of histamine, which is that chemical we were talking about, that are released throughout the body, this can cascade into a more exaggerated immune response. Now, in small doses, histamine causes vasodilation, increased capillary permeability, and bronchial constriction. So we can get a little short of breath. And then the vasodilation and increased capillary permeability helps to mobilize those white blood cells. We can get a little bit of swelling in the tissues. So all of that happens with histamine release. And again, as this gets more exacerbated, this is going to cause life-threatening problems. And that's where we get into anaphylaxis. So with anaphylaxis, we're having vasodilation. So what does that mean? That means dilation means basically widening, largening of the vessels, vaso. So we get vessels that are widening, and two things happen. We've talked about capillary permeability, so it creates leaky capillaries, and that's when white blood cells will mobilize and pool in areas, and that's where we get swelling. So we think of angioedema, which is swelling around the airway. So that swelling can increase pressure on the airways, And we know that this response can already cause constriction of the bronchioles, and the bronchioles are those lower airways. It goes from the trachea to the bronchi, those main airways that stem off our trachea. Bronchioles are slightly smaller, and then those terminate into the alveoli where gas exchange actually occurs. So those smaller airways can be constricted with histamine release, but as swelling occurs, it can actually put more pressure on the airway and further interfere with our ability to mechanically move air, so ventilate. So that's one issue with some vasodilation. Another issue is as those vessels essentially enlarge, now blood is pooling. So I like to think of a hose. As fluid moves through a rigid hose, the pressure kind of maintains the same. Now, if we flow that same volume of water through a larger pipe, let's say, the pressure goes down, right? There's less pressure behind it. You know that when you put your finger over the end of a hose, water comes out at a higher pressure because it's having to flow through a smaller area. The exact opposite occurs when you take your finger off that hose, it flows at a lower pressure. So when we dilate the vessels throughout the body, blood pressure within our body, because there's a fixed volume of fluid essentially. So as we enlarge in those vessels, we decrease pressure. As we decrease pressure, it's harder for fluid to move with enough pressure to the vital tissues and to the extremities. So we have this twofold issue of leaky capillaries and a lower blood pressure. Lower blood pressure means poor perfusion. Perfusion refers to oxygenated blood reaching tissues. So low pressure means blood has a harder time moving to these tissues. So now we have an issue of poor oxygenation of tissues. As this problem exacerbates, we get shock, right? So shock is poor perfusion. Shock can happen a multitude of reasons, right? We can have low blood pressure, we can have pressure on the heart, which prevents it from pumping effectively. We can have an issue with our nervous system that's interfering with vasculature and overall perfusion in the body. But then we can also have distributive shock, which is an issue with the dilation of our vessels. So anaphylaxis is distributive shock, essentially. And as it gets worse, our blood pressure will ultimately go down. So with shock, what usually happens is the body tries to compensate with this widening of vessels or this loss of pressure by increasing heart rate and increasing respiratory rate. However, as this problem goes on, the heart rate will eventually start to drop, and now we go from compensated shock, decompensated shock, and irreversible shock. We also, of course, have bronchoconstriction, like I mentioned before. Now, this bronchoconstriction paired with increased mucus production, we talked about that irritation of the mucous membranes. So we can have swelling around the airway, we can have constriction of vessels, and increased mucus. We know that air doesn't move very well past mucus. All you have to do is talk to somebody who has upper respiratory infection. And this really interferes with the ability to breathe, right? Swelling, constriction, and mucus production does not make for good passage of air. This ultimately leads to respiratory distress, poor perfusion, poor ventilation, and ultimately poor respiration. We know that ventilation is the movement of air, respiration is the exchange of gas, and oxygenation is the ability of oxygen to actually get onto the blood. So all of these are affected and we have shock. So what is the treatment for this? First, we want to ensure an adequate airway, ventilation, and oxygenation. At the EMR level, what does this really look like? This can mean supplying some oxygen. It can mean administering positive pressure ventilations, so with a bag valve mask or a pocket mask. And like I said, giving oxygen. The goal is to keep anybody's oxygen saturation above 94%. We're kind of looking for that 94, 96% range. The other big thing here is assisting a patient with an epinephrine autoinjector if it's available. So as we progress in levels, we know that we can carry epinephrine in our med kit or on the ambulance. However, at the EMR level, our option is to assist a patient with their epinephrine autoinjector. It's really important that you know how the ones in your area function. There's one end that the cap comes off, and that's the end that the needle is going to come out of, right? You want to make sure you don't accidentally put the wrong end to the thigh and put your thumb over the end, right? So we're never putting our thumb over the end of any sort of auto injector so that we don't get injected. You want to make sure that with swift, firm pressure, press it right into the middle of the thigh and hold it there so that the entirety of the medication can be delivered. Typically, this is going to range from about 0.3 to 0.5 milligrams of a 1 to 1,000 epinephrine solution. It's more concentrated, it's going into muscular tissue, and it's supposed to help the body react very quickly. If you are using an auto-injector, you don't need to know this, you're just injecting the whole thing, but it is good to know what's usually carried and utilized by EMS providers. It's also important to know that one dose of epinephrine might not be enough for a patient. So you might see some symptom improvement. However, the patient's symptoms might worsen again. So they might need repeated doses of epinephrine in order for their system to completely compensate for whatever allergen they were exposed to. So just because a patient's symptoms improve after you assist them with their auto-injector does not mean that they're cleared and ready to go home. They still need evaluation at the hospital and continued monitoring, especially if it was a bad enough reaction for you to assist them with an auto-injector, then they definitely need follow-up monitoring and care. And if they carry some sort of epinephrine auto-injector on them, then their healthcare provider knows they have a condition and knows they need to be monitored, so they definitely should not be going home. So transport them or call for some sort of transport if you are not able to transport or working with an agency that does transport. But epinephrine is the big one for treating any sort of allergic reaction and specifically anaphylaxis. So the conclusion for our course, deviation from a patient's baseline in their mental status is a cause for concern no matter what it is. Remember that AEIOU tips. It's important to perform a thorough and rapid assessment of the cause for their altered mental status in order for the patient's survival. So you need to be able to quickly assess if they have a deviation from baseline and then be able to pretty quickly perform a relatively thorough investigation of what could be causing that, especially focusing on ruling out those life threats first. Seizures are possible and somewhat common cause of altered mental status. So understand seizure evaluation, types of seizures, what can cause seizures, and what to look for in seizure behavior. Again, it's not always those grand mal seizures or now termed tonic-clonic seizures with the full body convulsions, right? They can be far, far more subtle than that. Next, we moved on to the endocrine system. So the endocrine system is central to homeostasis, and changes in hormone status may also affect mental status. So you need to understand the basics of the endocrine system, some of the glands involved in the endocrine system and what they do, and even some of the organs that have endocrine function. The big thing is diabetes, right? So we need to know how to recognize and treat diabetes, specifically hypoglycemia. We know that that's really rapid onset, like we talked about. So how can we help treat a patient before they need intravenous drugs or even intramuscular drugs? So if you can get those hypoglycemic patients to eat something with a simple sugar pretty quickly, that's key. So careful management is crucial for patient survival. Make sure that if that's something that you think is going on with the patient, you ask them about history and make note of that to the receiving providers or the receiving facility. If a patient has some sort of diabetic episode or issue with their blood sugar, that in most cases is going to require transport for follow-up evaluation, but make sure you're always following your local protocols. Allergic reactions and anaphylaxis are acute emergencies that the EMS provider may also manage, and it's something that you're probably going to see. They can range, right? So it's not always just a very simple allergic reaction or very obvious anaphylaxis. Sometimes they can progress. Like I said, sometimes those allergic reactions with repeat exposures can get worse and worse. So you have to be acutely aware of when a patient's symptoms are progressing to the point that they're going to need some intervention, and make sure that you err on the side of caution, because with anaphylaxis, the airway is in danger, and that's huge, right? If we can't access the airway, we can't support the airway, a patient can't move air or perfuse vital organs, they're in a lot of trouble. Epinephrine and oxygenation are important in the management of these reactions. My recommendation would be to ask for access to some sort of test epinephrine auto-injector so that you can play with it. They often come with 2 different colored caps, like 2 different colored ends, so that you know which end to put in the leg and which end to stick up. Usually something like orange to the thigh, blue to the sky is something that you might hear. And make sure that you never put your thumb over the end of any sort of epinephrine auto-injector. In the case that you do have it backwards, you don't want to be the one injected. Take that medication away from the patient. Make sure you hold that auto-injector in place to administer the full dose of medication, and make sure you still get that patient to a higher level of care for follow-up evaluation and monitoring.
All right, now we're going to do some multiple choice review questions. Question number 1. Your diabetic patient is experiencing symptoms of hypoglycemia. You test her blood sugar with a glucometer and determine that her blood sugar level is 63 milligrams per deciliter. She is conscious and alert. What is the proper treatment for her? The answers are: administer oral fluids with sugar or oral glucose. Nothing, her blood sugar is not at a level that requires treatment. Assist with administering her insulin, or rapid transport. The correct answer is administer oral fluids with sugar or oral glucose. If the hypoglycemic patient is conscious and alert, you should administer oral fluids with sugar or oral glucose. Rapid transport would be proper for a patient who is not conscious or alert. Administering insulin would further lower her blood sugar and is out of our scope. A blood sugar level under 70 requires treatment. Next question. Which of the following medications would be appropriate for a wheezing patient? Answers are albuterol 2.5 milligrams, epinephrine 1 milligram, solumedrol 2 milligrams, diphenhydramine 20 milligrams. Correct answer is albuterol 2.5 milligrams. Wheezing is indicative of swelling in the lower airways. Albuterol is a beta-2 agonist, which results in bronchodilation and thus improves airflow and reduces wheezing. Question 3. You are called to the scene of a potential poisoning. Your patient is a 21-year-old female who tells you that she swallowed an entire bottle of antidepressants. When calling medical control for permission to administer medications for this patient, which of the following medications would you most likely consider using? Answers are activated charcoal, an albuterol inhaler, epinephrine, or glucose. Correct answer is activated charcoal. Activated charcoal is indicated for a suspected ingestion of poisons. Activated charcoal works by binding to the poison and delaying digestion until the poison can be removed in the hospital setting. Next question. A 19-year-old male complains of abdominal pain. He describes the pain as dull and persistent and cannot point to one spot where it originates. It started the previous day and has gotten worse since. He describes it as an 8 out of 10, and nothing he does makes the pain better or worse. The pain is likely coming from where? Answers are damage to an organ or organs in his abdominal cavity, referred pain, tissue damage resulting from previous trauma, or internal abdominal bleeding. Correct answer is damage to an organ or organs in his abdominal cavity. Dull, persistent, and unlocalized pain is a potential sign of abdominal organ damage. It is unlikely to be caused by trauma since it has a slow onset and nothing has made it better or worse. Next question. Your 78-year-old male patient is suffering from sepsis. He opens his eyes when you shout his name, mumbles profusely, and only moves when you rub his sternum. What is his GCS score? Answers are 9, 11, 10, or 8. Correct answer is 9. On the GCS score scale, his eyes are a 3, verbal is 2, and motor is 4 for a total of 9. You were called to the residence of a 93-year-old woman. Her home health aide described stroke-like symptoms to dispatch over the phone prior to your arrival. The symptoms included numbness of the face, severe headache, weakness in the extremities, and difficulty speaking. By the time your crew arrives, the symptoms are gone. What is likely the cause of these symptoms? Answers are transient ischemic attack, stroke, head trauma, or migraine. Correct answer, TIA. A transient ischemic attack, or TIA, is also referred to as a mini stroke. The patient will have all the signs and symptoms of a stroke, but the episode is transient, so it will be present and then resolve. TIAs are known to be a sign of risk of future strokes. Next question. You are called to the patient who you suspect is septic. Which fluid dose is most appropriate for an adult patient in septic shock? Potential answers are 30 milliliters per kilogram IV, 1,000 milliliters IV, 2,000 milliliters IV, or 20 milliliters per kilogram IV. Correct answer, 30 milliliters per kilogram IV. Septic patients require correction of hypovolemia as well as restoration of adequate perfusion pressure. The recommendation for fluid resuscitation by the Surviving Sepsis campaign is 30 milliliters per kilogram. 10 milliliters per kilogram is generally considered a bolus dose for an infant. The other fixed doses might be sufficient, however, they could be too much for a very small person or too little for a larger person. Next question. Which of the following would not be useful in differentiating between a patient with diabetic ketoacidosis or hyperglycemic hyperosmolar non-ketotic acidosis? Potential answers are coma, a quote-unquote fruity odor on the patient's breath, CBG of 935 milligrams per deciliter, or Kussmaul respirations. Correct answer, coma. Patients experiencing DKA or HHNK can have altered mental status or be in a coma, so that would not help you differentiate between the two. A patient with HHNK usually has a CBG level above 650. A patient with DKA may have Kussmaul respirations in an attempt to blow off excess CO2 and a fruity breath as a result of ketones. HHNK does not result in the same acidotic state or the production of ketones, so Kussmaul respirations and fruity breath would not be present in these patients. Next question. Jugular venous distension, or JVD, if present, would be best seen with the patient placed in which position? Answers are semi-Fowler's, tripod, prone, or supine. Correct answer is semi-Fowler's. In semi-Fowler's, with their head turned to one side, will help you observe JVD best. This is the true sign of quote-unquote volume overload. Last question. You were on scene with a 68-year-old male that has been sick for 2 days with flu-like symptoms and diarrhea. The patient's family called 911 today because the patient began acting weird and is lying on the kitchen table. The patient had a doctor's appointment 2 days ago where he was prescribed prednisone, Tylenol, atropine, and Lexapro. After performing a physical assessment, you notice the patient has dilated pupils, appears dehydrated, and his skin is red, hot, and dry. Vital signs are blood pressure 126/72, strong radial pulse at 120 beats per minute. What is your differential diagnosis? Answers are anticholinergic overdose, sepsis, narcotic overdose, or heat exhaustion. Correct answer is anticholinergic overdose. Side effects of an anticholinergic drug, such as atropine, include acute psychosis, vasodilation, dehydration, elevated temperature, and pupil dilation. Remember the saying, mad as a hatter, hot as a hare, red as a beet, dry as a bone, and blind as a bat.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to emtprep.com. Until next time, stay sharp, stay safe, and stay on pulse.